Right. I've downloaded few graphs from Globocan itself. As you can see, like oral cancer wise, so it is not present in top 15 cancers around the world. So this is the global data. It is not among the top 15 cancers around the globe, oral cancer. But when you move on to the southeastern Asia, that is our region, India, Pakistan, Bangladesh, Bhutan, Nepal, our region, that is the fourth commonest cancer. So it's our problem. That is our problem. It's the fourth commonest cancer. And if you take the total number of cancer cases around the globe, two-thirds of the oral cancer burden is from low and middle income countries like Southeast Asia, South and Southeast Asia, Latin America, and Europe, certain European countries. And sadly, Asian subcontinent itself contributes to about 56% of the oral and oropharyngeal cancers. This is a sad fact, and we have to work on it. Next time, I'm gonna move into the geographic variation. So if you see these dark colored areas, that is where the cancer incidence rate is very high. As you can see, the dark color is surrounding us: Sri Lanka, India, Bhutan, Bangladesh, and Nepal, and certain African countries as well. So we find a lot of cancer cases in our region. And when I'm turning back into Sri Lankan scenario, it's the second in the list of most common cancers. That's a fact. I will go a little further. This is the commonest cancer among men in Sri Lanka. And this is ninth commonest cancer among females in Sri Lanka. This is the commonest cancer in Sri Lanka. Altogether, the second most commonest, total taken together, the second most commonest cancer. Fortunately for us, this used to be the commonest reason for cancer mortality a few years ago, but not anymore, right? So you can see this graph. It is in the sixth stage, yeah. Number 6, number 7. This used to be in the top oral cancer mortality, but now it has gone down. Something to be happy. Okay, let's see what the area we are talking about. Bit of a anatomy, right? So oral cavity or the oral cancer is considered the cancers appearing in the area from vermilion to the posterior border is the oropharynx. Basically, from the area where you apply lipstick and the area where you see when you shout at somebody, the back of the mouth. So that's your area, right? So cancers appearing in that area, hard palate, tooth-bearing tissues or the alveolus, basically. And anterior two-third of the tongue is considered the area of concern when it comes to oral cancer. This oral area is like surfaced by the stratified squamous epithelium, very famous stratified squamous epithelium, which give rise to these cancers as well, most of the cancers as well. And some note, we have a very rich lymphatic supply to the head and neck region, and we have about 300 neck lymph nodes bilaterally. And I mean, one thing to note is when cancer spreads into these areas, the prognosis is also like drastically reduces. You can get different various types of cancers in the oral cavity, but the commonest is oral squamous cell carcinoma. But you have other spindle cell carcinoma, basal cell carcinomas, and various other names. But when it comes to oral cancer, term comes with mostly the oral squamous cell carcinoma. This is a bit of academic, ICD level, where I have all these disease classifications. And it says the lip and oral cavity cancer, which is our area of concern, the lip, tongue, and oral cavity. Now when you include oropharynx, so they have given ICD 9 and 10 also there. And they have excluded salivary gland and other pharyngeal sites when you talk more on. It's a separate entity, but I'm going to talk to you about the oral squamous cell carcinoma basically. And more than 90% of the cancers appearing in the oral cavity are squamous cell carcinoma in histopathological type. How do they clinically present? That's really important. Right. I'm going to show you a series of pictures now. The cancers appearing, cancers presenting to us. And these are real pictures. Okay. So this gentleman has a lip cancer. Yeah. It's more of a very flat. In certain areas, you see a little bit of a raised areas, a growth, and some ulcerated areas as well. So this one form of one way of presenting cancers to us. Next is like whitish plaque with intermingling reddish areas like here. There are reddish areas here as well, but not in this picture. And this is whitish plaque, one way of presentation. Next, you see a widespread whitish lesions. Another cancer presented to us. I'm going to move to the next one. See, bit of a erosive intermingling white and reddish areas. This is a bit nasty. And these are, I consider these as fairly manageable, easy ones. Next, I'm going to show you a big one. And this is what we see in our clinics every day. We are going to talk why in few minutes. Right. This is another one. Nobody wants to see this kind of a cancer, surgeons. This is a nightmare. The nightmare. You can't operate on this kind of cancers. How do we deal with this? Right. I thought of talking to you a bit on how we deal with this. Then I'm going to talk to you on how you support us and how we are going to collaborate in the future as well. Right? How do we deal with it? We always basically start with confirmation. Usually, we confirm that with an incisional biopsy. Once it is histopathologically confirmed, we go through a panel of investigations, including CT, sometimes ultrasound, blood investigations, MRI, horn beam CT, which is a dental form of a CT. And we gather all the information. I'm sorry. Thank you, Basilu, and sorry about that small technical hiccup. We gather all this information and we go and talk all these details about what we're going to next in multidisciplinary meeting. We have multidisciplinary meeting every other Monday, and we get support from medical officers, consultants, oncologists, pathologists, general, oral, and physiotherapists. We have a support from physiotherapy department, AHS, and physiotherapy department of teaching hospital Peradeniya, speech and language therapists, everybody, almost all standard groups, which needs to be there in oral cancer, MDM. We have them coming every other week. Dr. Saman Rajaguru from Kandy Hospital, Dr. Roshan Gunaratna, and Dr. Senika Kandagir, all of them are coming to our MDM. So we make decisions based on the scientific evidence, and we operate on that scientific decision. Right. Then treatment of oral cancers. Traditionally, oral cancer being treated with surgery, and we still have the most frequently used or most accepted form of a treatment as surgery. In addition, we have radiotherapy, chemotherapy, and since 2000, mid 2010, we have evidence of immunotherapy and gene therapy in treating certain form of oral cancer. So which I'm not going to go into detail a lot. I'll show you one case next. So here we have a oral cancer I've operated. On the right hand side of the picture, we have this. One second. We have this tongue cancer on the lateral border of the tongue. The next picture shows how you see it after resection. And as you know, the tongue cancers has a very high potency of like very high chance of metastasis into the neck lymph nodes. We do a neck dissection, sometimes a bilateral neck dissection in posterior tongue cases. And once the cancer is removed, you need to reconstruct the tissue. That's a standard, global standard around the world. You need to rehabilitate. We treat this patient to live, so they have the right to receive the proper treatment. And fortunately for us, and we are really lucky, we have all these facilities in the dental hospital Peradeniya. We have 2 dedicated dental theaters with 3 ICU beds. So we do all these advanced reconstruction techniques. This is a radial forearm free flap harvested. And this is me and my great teacher, Professor Manjula anastomosing the artery and vein. This is two different cases. We have a nice microscope as well there. Right. Next, what you see is anastomosed vessel. It is about 9 times magnification. Usually these vessels are about 2 millimeters or 3 millimeters in size. So this is after anastomosis. And this is what you see. So just on the first post-op day, this is what you see. A very nice, healthy flap. Right? So usually these surgeries are long surgeries, but they get the standard treatment. I've been working in United Kingdom for 2 years. This is what they do in UK, and we are very glad we do the standard treatment in our hospital. They always do reconstruction with free flap transfer, free tissue transfer, because local flaps or any other flaps has a lot of limitations and post-operative complications. We always look for the free flap transfer. So whenever necessary, it's not that we are doing the free flap transfers always, but whenever necessary, whenever it's scientific, you always go for the free tissue transfer there, right? Then the rehabilitation, we have a huge rehabilitation team. We have our own speech and language therapists, training them on speech, swallowing, mastication. Also teaching hospital, physiotherapy unit or the teaching hospital, they're helping us a lot. And Department of Disability Studies, Faculty of Medicine, University of Peradeniya. So they are helping us. They're coming tomorrow as well to have a discussion and see some of our patients. Also Department of Physiotherapy of the Faculty of Allied Health Sciences. So with all these inputs, we have a very nice outcomes, I must say. So this gentleman, I have the right of, I have the permission to show this video. දිවේලියට දාන්න බලන්න. වම් අත පැත්තට දිව දාන්න. අනිත් පැත්තට කරකවන්න. හොඳට ඇතුළට ගන්න. right කෙල ටිකක් ගිලින්න. වතුර ටිකක් ගිලලා පෙන්නන්න බලන්න. හරි. හරි. හරිසිංහ මහතා ඇඩ්‍රස් එක කියන්නකෝ. So Mr. R.A. Singh is a very nice gentleman who had a tongue cancer. We have resected and reconstructed with a free tissue transfer, radial forearm free flap. This is second post-op month, as I guess, after course of rehabilitation in the Life Health Sciences Department and Physiotherapy Unit. He's doing fine and he's having a very nice life now. He's enjoying his life. Again, eating. Okay. Next, this is a case of soft palate cancer. We have reconstructed with a radial forearm free flap again. So when the bone is involved in oral cancers, we do resections of bone and we reconstruct with fibula free flaps. And I'm going to show few pictures borrowed from Professor Manjula article because I didn't have clear pictures of my cases. And Professor Manjula article's case is a maxillary cancer where he had to undergo orbital excentralization nasal because his cancer was spreading to the eye. So we have done that. And fibula prefab harvesting, and we have a 3D model printed on that side that helped us a lot. So we use all these, whatever available. We have a nice 3D lab, malfunctional for some time, but back in function again, right? This is after inset and suturing, just after suturing. That's him. Now, again, he's having a nice life now. He's a very young boy, presented to us with a unfortunate cancer. Now he's back in the back in his life. Yeah. Not always we do very big advanced reconstructions. We do simple reconstructions as well. This is a lip cancer treated with a local flap. Sometimes we use buccal fat pad to reconstruct or cover the defect after cancer excision. So this is what we do, various different things. And again, we review all these patients in multidisciplinary meeting. Based on the excision findings, we decide on further treatment. Yeah, most of them, some of them, I would say, needs chemo and radiotherapy. So candidate hospital and medical officers, they help us in carrying out the rest of the treatments. And I must thank all of them, right? So next I'm going to talk to you about the medical practitioner's role. That's the second part of my lecture. So what I've spoken to you up to now is what we do, and next I'm gonna thank you for what you are doing, what you have been doing, helping us, and also to improve or just make more collaborations, more like to ask for more support in the future. Early detection. This is really important. Why? If you take all cancers presented to our hospital, or any other hospital in the country, you know how you calculate the survival, the 5-year survival rate. How many of them are living for 5 years? When it comes to oral cancer in Sri Lankan scenario, we have a 5-year survival rate of 50% of the cases because they present at the latter stages. If these cancers present to us at early stages, like stage 1, their survival is more than 80%. But unfortunately, most of the cancers, Loshan would agree with me, are presented to us at the stage 4, where the survival is less than 20%, sometimes 15%. And that's a real disastrous situation. And I've gone through the recent data from the National Cancer Control Program. If you see, the things are improving anyway. The stage 4 cancers, we have about 29% of cancers are presented in, nearly 30% presented at the stage of stage 4. And if I have taken to you, if I move to the next graph, now from 2005, cancer incidence is rising and still rising. And there's a sharp rise among males as well, right? This could be probably due to some other fact. People may be more aware and they are presenting to the hospitals. That could be that. But still, for some reason, the cancer incidence is rising. We need to act on that. Key to good prognosis is early detection. That's the key. We need help in this aspect. Fortunately for us, like in a signal lamp, before healthy mucosa moving into a cancer, we have a pre-malignant stage. Usually in most of the cases, that lasts for about 1 to 2 years. So we have a huge gap where we can diagnose. And this is how the pre-malignant lesions or the precancerous lesion or potentially malignant lesion in the proper terms present to us. This is one way called oral submucous fibrosis. Oral submucous fibrosis is appearing due to areca nut swing, and you get blanching of the mucosa, leatheriness of the mucosa, and reduction in the mouth opening. And I mean, when you palpate the cheeks, they are really, really leathery, not very soft, right? This is one way of presentation. The malignant transformation rate of this one is about 8% in our country, 8 to 13% in certain scientific texts. But in our country, it's about 8%. So you can save a life if you see them in one of your OPD clinics or a health camp. Please send them to us. Next is the white lesion, the common leukoplakia. A malignant transformation rate is about 5%. 35% is a different form of a leukoplakia. Basically, it's about 5%. If you detect them at that stage, again, please send them to us. And erythroplakia, the red lesions are nasty one, and the malignant transformation is about 50%. And the lichen planus, even though this is a reticular innocent variant of lichen planus, but you may see lichen planus with erosive areas. In the literature, international literature, it's about the malignant transformation is about less than 2%. But unfortunately, in our country, we don't see that much of a malignant transformation rate. But still, it's good to have a little look closely in our clinics. So have a regular follow-up. My key to detect whether this lesion should be looked at or not is if anything or ulcer, white lesion, red lesion is present more than 1 month without healing, that needs an attention in a proper medical setup. So that's the key. Let me take you through the prevalence of oral potentially malignant disorders. We have oral potentially malignant disorders about 1 to 5% around the globe, if you take the population as a general. But in our country, the high-risk group is rural and estate population. They have a prevalence of about 11%. That's available data, 11%. If you go and screen people, laborers from the estate sector, you will find about 11%. This is a study done in Sri Lanka by Dr. Professor Hemant Amarasinghe. And sometimes they present with exophytic mass, area of abnormal mucosa, cervical lymphadenopathy. If it is spreading somewhere, alteration is towards the vocal cords, alteration of the voice, and if they involve cranial nerve, you will see cranial nerve lesions. Then the screening. Screening has shown very good results around the world in countries like us. There were 2 popular studies in India, one in Kerala, India, one in Cuba. They have shown the remarkable shift in the stage of diagnosis. You know, if you diagnose them at the early stage, we have a better prognosis. Also, there's one study, a Trivandrum oral cancer study, that says the morbidity, cancer mortality, changes or reduction from 34% in if you plan a proper screening program. Right? I believe this is the role of medical officers in managing oral cancer, early detection. So opportunistic screening, sometimes they might be present to you for the regular management of hypertension, diabetic, or any other medical illnesses. Take a moment to have a look through the mouth. If you have time, take a moment to have a look through the mouth and see whether you see all these lesions. If you can detect them, you are saving a life. You're saving a life. Definitely, you are saving a life. If the abnormality is identified, you can refer them to a dental clinic or a nearest dental surgeon, your colleague, or a maxillofacial surgery unit or oncosurgery unit. I'm sure most of you are involving managing or involving organizing all these screening programs and medical health camps. Take your dental surgeon friend with you. Take your dental surgeon friend with you. Get them to see if you are the patient. You might find one that will save somebody's life, right? Also, I know there are some medical officer of health in this online audience or maybe around us, and get your public health workers or the work public health midwife, PHI, and your team to engage in these activities. That's what we can ask from you for the early detection of the cancers. Keep in mind, in Sri Lanka, these are the high-risk groups: estate workers, laborers, bus drivers and conductors. We see a lot of cancers in them, among them, and three-wheeler drivers. So if we find them, make it a habit to have a little opportunistic screening. You might find one or two cancers. Apart from this, anybody else who choose one betel quid a day or do betel chewing, smoking, and consume alcohol or consume commercial areca products are candidates for screening. And these commercial areca products, which I'm going to talk to you in a few minutes, is the biggest problem among schools now. We find a lot of kids with oral potentially cancerous lesions. We have been to a school very recently, and like surprisingly, we see some of these lesions among school children because of these commercially available areca products. And I believe you should be aware of the risk factors for oral cancer. As you all know, smoking, not only oral cancer, smoking is harmful for some other medical conditions and medical diseases as well. And chewing tobacco, snuff dipping, alcohol misuse, and betel quid and syphilis. So those are the established risk factors. And as you all already know, the human papillomavirus has some potential to cause oral cancers in the mouth. Sometimes you might find one or two cancer cases appearing in the mouth without any cause. When we screen them, we find human papillomavirus. This is an emerging trend, but fortunately, they have a good prognosis. So, be mouth bare. Some pictures again. Smoking. Some chewing tobacco products. This is very common among school children now. Alcohol, very nice to look at, but very harmful when it comes to systemic health, oral health. Areca nut and betel quid. One thing I've seen is betel chewing is not more fashionable habit. The number of people who are chewing betel is declining now, going down, because it makes your mouth red, because it stains your teeth. I don't think anybody would like to have bad stained teeth. Now the trend is declining, but unfortunately, we're getting this in the market, substitutes for this, right? We see all of these in front of schools, and school children are using this. And it's a very unfortunate situation, right? As you've seen, we do a lot of big surgeries. We need your support. You always thankful for you. And we need your support in optimizing patients prior to surgery and during the perioperative time. For the pain management, nutritional support. We have specialized team working in the nutrition, but we might send the patient back to you for the follow-up. So we need your support because these patients, when they present to us, they are nutritionally very weak. If we start playing on a bad wicket, our scores will be low. So we need to start on a better wicket. So we improve the nutrition support. Lasit and Malika, they were our nutritional team, and they were helping us. Lasit, a nutrition physician, and Malika together. And the medical officers involved in the team. So they prescribe, and sometimes we obviously need your support in managing all these patients. You might find some of these patients with medical illnesses. So please help us in optimization. maybe diabetic, maybe hypertension, prior surgery, post-operatively, because that will help us a lot. And psychological support. You know, when you have a oral cancer, when you have a painful oral ulcer, declines your psychology. You are scared. And nobody wants to have scars on the face. Nobody wants to have scars on the face. And your mouth, now after surgery, everybody knows you're not going to talk normally. You're not going to eat normally. So they are psychologically affected. You might be the source of their motivation. You'll be the source of their motivation. I'm sure, of course, you are doing us, you are helping us a lot. So motivate them. And biggest help we ask from you is motivation for the treatments. They are really scared of the treatments. They are really scared of the diagnosis. That's one reason why they present to us late. They don't want to have the surgery. They are not aware of their fate. They think this will cure. Sometimes they have kids. Recently, I had a patient who had a disabled daughter of 21 years. Because of that, he doesn't want to get a treatment. Like, he's coming from Mahangane. And unfortunately, we are still trying to get him for the treatment because we know the fate of it. We might need your support in that situation to motivate them for the treatments and family support. Some of them have kids, schooling kids, they need support, financial support. We all are involved in various different organizations, funding organizations. Sometimes you might help them to have a little support until father or mother gets the treatment. Please help us in that. And post-operative wound care. So next is a case which we have done. We have reconstructed the pectoralis major myocutaneous flap. You know, there's a small wound breakdown there. Now this is healing. Now for this tiny lesion, we don't need to keep the patient in the hospital and waste government money. We can send this patient with proper instructions. What we normally do is we ask the patient to go and visit your nearest medical officer to for the regular dressings. So when they come back, this is healed. So we need support in that aspect as well. And there's a role in rehabilitation as well. Usually these patients are having speech, swallowing, masticated problems. They get problems in the limb movement sometimes with the neck dissection, you know, accessory nerve is stretched during the neck dissection. So you might get problems in the limb movements, sometimes after fibula free flap harvesting. So there's a bit of a rehabilitation activities afterwards. We need your support in rehabilitation as well. So on all these activities, this is one big problem we face. A lot of patients are lost to follow up in our clinics. Yeah, you might find them. You might find them in your screening clinics. You might find them in your regular medical camps. So ask them to go. If they haven't come to hospital, they think they are cured, or maybe there was a miscommunication in follow-up appointments. Please ask them to go because they need at least to have a follow-up for 5 years. They need to have a follow-up of 5 years at least. In the first 2 years, monthly. Next 3 years, at least 3 monthly. They need a follow-up. And some of the cases are inoperable. Look at this case. This is a 38-year-old lady. Very unfortunate. She has 3 kids presented to us. This is the presentation. This is not operable. So this is for palliative care. And you know, there are various aspects of palliative care, and we need your support. And I'm sure there are various different organizations and various different hospitals, clinics working on these palliative aspects, medical offices working on palliative aspects. Help us in this aspect because they deserve a decent death. Screening of high-risk individuals. And you can train them to do a self-screening. It's very easy, right? Ask them to go in front of a mirror. This is the last slide. Ask them to go in front of a mirror. Have a good light in the bathroom, maybe. So ask them to start from one corner of the mouth, fold the lip upwards, ask them to see through. Then the right side cheek, lower lip, left side cheek, palate, tongue, floor of the mouth. You can do it for patients, or you can get your team to train to do this, or you can ask patient if they are really uncooperative to do this. This simple screening will save somebody's life if they know it. So the take-home messages: the lip and oral cavity cancers remain one of the commonest reasons for cancers, one of the commonest cancers in Sri Lanka. So early diagnosis, as I mentioned to you earlier, is a key and the most critical factor in prognosis. So it's a multidisciplinary care. You are involved. Every one of us is involved. So help us, be in the team, be on board. Everybody has a role, clinical role. So both surgeon, and there are surgical interventions, non-surgical interventions. Be in the team and help us. And public health aspects, it's really important to have a proper screening and prevention strategies, awareness. Let us do this together. Thank you.